600 and the window width is kept at 2000 and we do that using a sharp corner. If we take images of the pelvis and lower abdomen, they are reconstructed in soft tissue window setting, that is the window level is kept at 40, the window width is kept at 350 and we do it using a smooth corner. So coming to the patient preparation and positioning, now this is not only specific for CT pulmonary angiography, this is specific for all post-contrast CTs and to some extent all post-contrast MRIs in general. So the most important thing is we should always check the renal parameters of the patient, specifically the urea value and the creatinine value. Urea value of less than 40 and creatinine value of less than 1.2 is considered to be safe. In case of females, all heart heart attacks and MRI, because it is we are subjecting the patient to a high magnetic field. We should always take history of any contrast allergy. We should maintain adequate hydration of the patient, and last but not the least, we should always take an informed consent from the patient. Informed consent from the patient party is taken in case of minors, that is any individual who is below the age of 18 years, or in case of unconscious or disoriented patients. The patient positioning. The patient basically lies supine with the arms placed up and the arm is kept away from the lung field. Adequate IV access using an 18 to 20 gauge cannula is done. Contrast agent, this I have discussed in the previous slide, that is we use IOX1 and the dose and pressure are as follows. So coming to the basic indications of CT pulmonary angiography. The most important indication is pulmonary embolism in case of adults. Now pulmonary embolism, it can be broadly divided into two groups, that is thrombotic and non-thrombotic embolism. Now thrombotic embolism can further be subclassified into acute and chronic cases, which I will be discussing in my later slides. Now this image I have taken from European Respiratory Journal. This describes the different causes of non-thrombotic pulmonary embolism. It can be fat embolism, amniotic fluid embolism in case of pregnancy, tumor embolism, gestational trophoblastic disease, that is in case of high age more in case of females. Then there can be septic embolism, that is following infections like endocarditis. There can be infective causes like hydatid cyst. There can be foreign material embolism or particulate embolism in case of IV injection, and the most dangerous is the air embolism, which can occur, which can be following post-traumatic or due to some iatrogenic procedure like central venous cannulation or surgery. Other indication in case of adults, for assessment of bronchial arteries, we also have a separate technique, that is CT bronchial angiography, but sometimes in CT pulmonary angiography we can also assess the bronchial arteries. Secondly, for assessment of aortic pathologies like aortic dissection and aortic aneurysm, this can also be sometimes seen in CT pulmonary angiography, and there is a newer entity, that is a triple rule-out CT. Triple rule-out CT includes three basic techniques, that is CT pulmonary angiography, CT coronary angiography and CT aortography. The basic purpose is to look for any cause of acute chest pain. Acute chest pain can either be due to the involvement of coronary artery, this can be either due to involvement of the aorta like aortic dissection or aortic aneurysm, or there can be due to pulmonary thromboembolism or any other opposite causes of the pulmonary artery. In pediatric age group, again, one of the biggest indications of CT pulmonary angiography is to look for pulmonary thromboembolism. Thrombotic, it can be acute or chronic. Non-thrombotic, mainly air, fat, septic and tumor embolism. Another big domain of CT pulmonary angiography is the congenital heart disease in pediatric age group. This I will not be going into much detail because this will fall under a separate topic. So basically, in congenital, now I will be discussing a couple of adult cases of CT pulmonary angiography. So my first case, this was a 45-year-old male patient. He presented in emergency with severe respiratory distress and dull aching chest pain. He had a recent history of high altitude posting. So ultimately, after proper clinical examination, NCCT chest with CT pulmonary angiography was done for this patient. So I will be displaying some cine loops. So firstly, I will just discuss in short about the basic anatomy. So this is the Chief Medical Superintendent's Office to evaluate Regional Area Hospital, Chapter 2. I will be represented by the radiologist, Mr. Rajiv. Unfortunately, I will be not available tomorrow, but I request everybody to be present and listen to this topic, please.
as most of the radiographers that come from different divisional hospitals, and as you can appreciate that in the last couple of years or last decades, many divisional hospitals they have started ultrasonography. But over the years, majority have either discontinued their services because of some procedural problems, lack of interest, and many other factors. And Dr. Mr. Rajiv will elaborate how the divisional hospital Chakrabarti has undergone a 360-degree changes within a period of 5 years, starting from basic X-ray to CR system, then advanced digital radiography, ultrasonography, the Doppler, and a total X-ray and endoscopy. And he will elaborate you and clear the doubt of anybody, so that those divisions which have already started, they can continue the process with little support from the state government and with the doctors. So once again, I request everybody to be present tomorrow to listen to him. And today's topic is about MRI in lumbar spines. And I present before you Dr. Saurabh Bera, who needs no introductions. He is a very dynamic, very brilliant radiologist of Central Hospital Divisions and one of the drivers of our radiology department of Garden Ridge. Dr. Saurabh Bera, his topic is MRI in lumbar spines, and I hope everybody will be benefited by his talk. Now the floor is open to Dr. Bera. Please continue, sir.
Thank you, sir. I will just try to make you understand the basic findings and the protocol of MRI lumbar spine, and to familiarize you with the very common findings we are find in day-to-day practice. So my topic of discussion, the basic anatomy and the MRI protocol, the lumbar disc herniation with the nomenclature. Sometimes this nomenclature are very confusing and extraforamina. The same thing is on the axial image. Now this is the lateral recess, the place laterally. It is your ligamentum flavum. Ligamentum flavum is a strong ligament in the neural canal posterolaterally that bind at the adjacent vertebra up and down. And with some degenerative changes, this ligament can be got hypertrophic and produce the canal stenosis. So this is the nerve root, this is the foramen, neural foramen. This is the facet joint. Facetal arthropathy is a common pathology here. This is the posterior spinous process, it is a transverse process. This is the vertebral body. Within the vertebral body, the nucleus pulposus, that is centrally, and annular fibrosis situated peripherally. So this is the MRI in that T2 sagittal image. This is the disc level in the sagittal image, and this is in the axial image, the disc level. Just come below, this is the below disc level, this is the lateral recess at the level of lateral recess. Further below, the lateral recess is continuing and the nerve root here. Further below, this is the foraminal level where through the foramen the nerve root is coming out. And further, the nerve root already comes out. This is the extraforaminal level. So in the MRI, we are seeing at this level for the what causes the nerve root compression, and it is to be mentioned in the reporting. So from above downward, this is the disc level, this is the below disc lateral foramen, this is the lateral recess, and this is foraminal, and this is the extraforaminal. Now, during the MRI, in the protocol, if you are working in the MRI, there is a phase encoding and the frequency encoding. This is very important. The phase encoding should be done craniocaudally and frequency encoding anteroposteriorly. Few of the today's machines already have the setup like this, because if you dump the frequency encoding above downward, there will be more the respiratory artifact. And if you done the phase encoding anteroposteriorly, there will be the others, the fat artifact and the streaking marginal artifact will be there. The problem is there. So saturation band should not be used nowadays. Previously, the saturated band was used to nullify the findings of the prevertebral space. We are more concerned about the vertebra, but it should not be used because the paravertebral area is very important. You have to see the retroperitoneal structure, some problem with the aorta and its surrounding area. There may be some pathology. So saturation band also should not be used. And regarding the axial segment, some of the situations, some of the institutions do the continuous axial segment. But some of the institutions do the axial segment according to the disc level. But continuous is always better than this discrete level. It takes more time, more film should be given. That's why the private setup usually do it in static way. Do it differently in individual disc, but it should be the parallel and continuous above downward to give you a continuous segment. And in continuous segment, we can trace the nerve root properly, not in the discrete segment. So, few cases is the T1, T2 and the star sagittal image shows some of the paravertebral collection which shows the enhancement, classical port spine with the paravertebral space and the vertebral degeneration and loss of height and with the central wedging. Another cases also in the T1, T2 and star. Star is a fat suppressed technique. You can identify the star image that the fat is suppressed here. T1, T2 in both images the fat is hyperintense. And here also the problem multiple vertebra, this is the vertebra plana and this is also the reduce the vertebral height centrally with the central wedging with the degenerative changes. Now the normal disc is containing of the nucleus pulposus centrally with the annular fibrosis laterally. And it should be confined to the normal intervertebral disc level. That is the within the disc, within the margin of the upper and lower end plate. Should not go beyond the end plate. And in normal sagittal section, it is also confined to the normal alignment of the vertebra. Should not go extend or beyond it. Now what happens if there is disc bulge? The nomenclature is circumferential disc bulge. It may be the symmetrical or the asymmetrical. If it is symmetrical all surrounding, then you will call it symmetrical disc bulge. If it is asymmetrical, then it is asymmetrical, more towards right, more towards left, that can be mentioned. And another two important nomenclature is the disc protrusion versus the extrusion. The protrusion is where this base margin is more than the margin at the protruded area. Now this extrusion or protrusion or the disc bulging can be divided according to the area. So simple, this is the posterior most in the central area, so the central canal zone protrusion. Now some of the two images showing a central wide-based protrusion. This is a cervical image, wide-based right paralateral paracentral protrusion with the lateral recess stenosis. It is also lateral recess stenosis and the right lateral recess and right paracentral protrusion. Now the annular fissure is the another term, that is the nucleus pulposus goes through the annular fibrosis through a tear and this material can come out. And after coming out, it can goes to migration, that is a caudal migration or the cranial migration. So this is the cranial migration and this is the caudal migration with sequestration. This is the annular fissure along with the disc herniation. There is another cases of the annular fissure, looks like this. There is a longitudinal annular fissure posteriorly. This is another interesting cases. In the sagittal image, we see some low intensity structure coming out from the disc. So there was a thought that it was low intensity in both T1 and T2. So it may be calcification, maybe the disc material. So it was thought that there is a disc material protruded with the calcification. So
the radiating pain in our legs, and how does it work? I think I just want to say how does it work in our?
It is nothing to do with the anatomical region or nothing with the cause. It is just the neural pain delivery. Neural pain जो है इसको वो demolish करता है, has nothing to do with the level of compression or anything in the anatomical. Now see, the compression, the first is the conservative. With the drug, along with the exercise and along with some muscles antispasmodic and with this true, very commonly used drug, pregabalin and the vitamin B12 cobalamin. But if it is not, the MRI says that not there is an anatomical compression along with the myelopathy. The compression when it gets long time in the MRI, we will see there is a change of signal intensity in the spine. Now if the change of signal intensity in the spine, if the patient's symptom is very severe, he can't tolerate the pain, the age, if it is common in age and the nature of work he is doing, if he is very prone to have a slip disc or like that, then you should switch over to another modality of treatment. During the another modality, there may be the discectomy, the disc protruded backward and compression to the nerve, so you can cut the disc. Another modality is give some injection, some steroid, something in that particular region, give some drug that will also helpful for the local. But anatomically there is a change in neural intensity or change in myelopathy, and the symptom is severe, patient is young, you should go for a discectomy. And these drugs are just the pharmacological drug, they are some neuroanalgesic inhibitor that will alleviate the patient, relieves the pain, only the neural. They not only cause for your back pain, neural compression, any pain, any neural pain they will act upon by less feeling of the patient by the pain, but does not cause anything with the anatomical region or does not treat the cause of that pain. Okay.
Thank you, sir. Any more questions from the audience? And thank you, Dr. Vera, for a beautiful and nice lecture.
Sir, I have one more question. Sorry.
Please take.
You said that some air is produced in nitrogen and some only in nitrogen, no?
Nitrogen with some amount of oxygen and
How
carbon.
does it flow?
No, the pathology is not clearly understood till now. This is actually an aseptic generation of the gas. Now we are very common findings in day-to-day practice of the advanced degenerative changes. So it is postulated that due to the degeneration, there is some aseptic gas production in between the two vertebrae, and gas will appear hypo-intense, dark line in your X-ray. In X-ray, it is a very dark, gas is dark because of the chest X-ray and intervertebral disc. So if you see the intervertebral strip of air within the intervertebral disc, that is known as the vacuum phenomena. Now vacuum phenomena along with the degenerative changes, you can tell the patient that your problem is chronic and it is an advanced degenerative changes. How the gas is produced, that is nowhere it is written, it is not postulated, but yes, that is a nitrogen and combination of minor oxygen and carbon dioxide. And please remember, this gas is not like a subcutaneous emphysema or not like the emphysematous pyelonephritis. You know, the gas accumulation is always awesome to the radiographer and for the radiologist, because the gas forming organism is there that will producing the gas. The chronic emphysematous pyelonephritis, chronic emphysematous gastritis, chronic emphysematous cholecystitis. Everything we picked up the findings through the imaging by seeing the gas in the wall. Maybe the bladder wall, maybe the stomach wall. So gas forming organism is always dangerous. But please remember, and you should assure your patient that this gas is not any problematic. It is the aseptic. There is no organism. There is no infection. This is the aseptic accumulation of the gas, mainly the inert gas nitrogen and oxygen carbon dioxide. There is no question of any infection and it is not associated. Okay.
Now, and thank you, Dr. Vera, for a beautiful and nice lecture.
Sir, I have one more question. Sorry.
Please take.
You said that some air is produced in nitrogen and some only in nitrogen, no?
Nitrogen with some amount of oxygen and
How
carbon.
does it flow?
No, the pathology is not clearly understood till now. This is actually an aseptic generation of the gas. Now we are very common findings in day-to-day practice of the advanced degenerative changes. So it is postulated that due to the degeneration, there is some aseptic gas production in between the two vertebrae, and gas will appear hypo-intense, dark line in your X-ray. In X-ray, it is a very dark, gas is dark because of the chest X-ray and intervertebral disc. So if you see the intervertebral strip of air within the intervertebral disc, that is known as the vacuum phenomena. Now vacuum phenomena along with the degenerative changes, you can tell the patient that your problem is chronic and it is an advanced degenerative changes. How the gas is produced, that is nowhere it is written, it is not postulated, but yes, that is a nitrogen and combination of minor oxygen and carbon dioxide. And please remember, this gas is not like a subcutaneous emphysema or not like the emphysematous pyelonephritis. You know, the gas accumulation is always awesome to the radiographer and for the radiologist, because the gas forming organism is there that will producing the gas. The chronic emphysematous pyelonephritis, chronic emphysematous gastritis, chronic emphysematous cholecystitis. Everything we picked up the findings through the imaging by seeing the gas in the wall. Maybe the bladder wall, maybe the stomach wall. So gas forming organism is always dangerous. But please remember, and you should assure your patient that this gas is not any problematic. It is the aseptic. There is no organism. There is no infection. This is the aseptic accumulation of the gas, mainly the inert gas nitrogen and oxygen carbon dioxide. There is no question of any infection and it is not associated. Okay.
give a certificate and a memento to the speaker, Dr. Sologara. Now, sir. Thank you. Thank you, sir. Thank you, sir, for your kind cooperation, sir. And this the presentation will be done by Dr. Amit Balani, SCSD Northern Railway from New Delhi, and the chairperson to chair this session, Dr. N.K. Singh, CMS Adra, and Dr. Srikumar sir, Chief Clinical Specialist, Central Hospital Guardians.
Good morning once again. Now we have got a very eminent speaker, Dr. Amit Balani, ACHT Central Hospital, Northern Railway. He has done his post-graduation from Patna Medical College in the year 2002, and he has fellowship from European Society of Radiologists in abdominal radiology. He has presented various papers, posters in national and international journals, and he has got 6 awards in the areas, including the Ministry of the MR Award. So it's a very interesting topic, as we know that after Google, the next thing is ChatGPT and other things. So now he has come with a very novel topic, artificial intelligence in radiology. Over to you, Dr. Amit Balani.
Good afternoon, the dignitaries on the dais, ladies and gentlemen. So, previous 2 sessions was on CT and MRI, which was very elaborate. Mine is a bit smaller one, and I'd like to have an interactive session, more of a kind. So, everyone knows what is intelligence. Everyone is having some kind of intelligence. But what is artificial? Today I'll be speaking about this, artificial intelligence. And what does it have a role in radiology? Everyone uses Facebook, is on social media, uses Instagram and various kinds of social media platform. Everyone uploads their pictures, their statements, their voice, they sing and upload it. For you it is memory, but for others it is data. Just imagine what is data? Basically anything which is in the bits and bytes, which goes digital, is known as data. Now we'll classify it, what is data and how many types of data are there. We'll all see later in the coming slides. But just let me put down some numbers for you. It will be interesting. Just see the guy or the person sitting next to you. He shares 99.5% of DNA with you. Only 0.5% of DNA is different. So it seems very simple. Oh, just 0.5% DNA is different. That means we must be same. You're not. Absolutely not. This 0.5%, if you do the maths, it translates to something around 8 million base pairs. 8 million base pairs are different, and which is not being given, it is being avoided in Herceptin negative patients with CFS. Why is it so? Because if we start giving this drug to every CF breast patient, it has cardiac toxicity. That is why it is being individualized and tailored. They have evolved. So does radiology need to be evolved. Why do we need to know all about these? What is data? What is big data? What is machine learning? What is deep learning? It is because we need to evolve ourselves. We just don't need to sit down and relax that we are doing CT angio, MRI and dynamic and these imaging, that imaging. No. We have to evolve ourselves to sustain. As I told you, the social media, sensor, the internet is everything, everywhere now. You can't escape. Imagine when we were kids, we didn't know what mobile phone was, what internet was. But see our kids, they are born and they start using the smartphones and all. So we have to be aware of these mobile techniques, the machine learning, the analytics, the artificial intelligence. We should know about cloud, and this is knowledge. Well, I'll come back to this slide later. So what's big data? Is there any definition of big data? Can anyone tell me what is big data? Data which is big, it is relative. It has no definition. The big data has no definition. The data is in millions and millions of data can have velocity. Means the data is not static. It can move. So we have to harness that also. It can have variety. It's not that you can have only PDF files at one place. You can have a mixture of files. You have to separate it. It can have variety.
We must update ourselves, otherwise it will be a boomerang effect. What deepfake videos are now doing. So if we are not convinced ourselves and just blindly accept what Westerns they have taught us, then it may be counterproductive for us. So there must be some regulatory mechanisms to regulate in this part of our life.
Well, unofficially off the table, I want to share that I am in talks with Hewlett Packard. There is a corporate social responsibility scheme which they have entered into, and they'll be coming to Northern Railway Central Hospital very shortly. AIIMS has started their artificial intelligence app. They are into it. They have not started, they are into it. So I'm also thinking about initiating some kind of reporting with artificial intelligence. So I am in talk, let's see. I'm not sure how much time will it take, but it will take.
Thank you, Dr. Sir.
Thank you very much.
Thank you, Dr. Sir. It is my first learning about AI and data collections and artificial intelligence. Whatever you have in every, not an initiative step, but it has a long history on that. Recently we have come across a news when a disease could not be diagnosed by 74 super specialty doctors. But once in a while it was diagnosed by the AI, it is very rarest of rare. You have already answered what is my query, whether AI can replace our experts, radiologist or medicine or cardiologist. But still, intelligence is something. Intelligence and AI is at par, running parallel. We have to take both those systems in together. And that is in the Indian Railway. We have taken that interest on AI and machine learning. We have HIMS, and it should be integrated all over Indian Railway. It is a very big asset. When you want to have a big data, so it requires big data, and it's the best platform to collect the big data and analyze all this big data, when we can plan for our future management or diagnostic, whatever it is, in a positive way. So this HIMS should be, first you have to collect the data, systematical data, what you have taken, organized the data in different ways, and there are so many data in a big data collections, that should be in a planned way, in a section, so that anybody from anywhere can see the data from different division of even health units. It will be much more better for the health management system in our Indian country, and basically it will be example for the national health plan. So thank you for this interest of taking this AI and data analysis in our medical system. Thank you.
Any more questions? Yes. You're not audible, please.
I just want to take it for a bit explanation. But in the last part of the session, we have mentioned the In the last part of the session, we have mentioned that this AI things is the utilizing the radiology, pathology, and other departments. So, like, does it pose a threat to the security of the job, or it show them how to be address this problem? Like, as a radiographer, what can I do just to keep in point with this technical advancement?
Okay, your question is very valid. Being afraid is the biggest thing that will lead to your progress. If you are afraid that you will lose your identity, then you'll progress. Because having said that, I mean to say AI, whenever it comes, it is not going to replace you. It will reduce your monotony of work. You are bringing the patient, you are placing him, you are exposing him. This all thing will be done by AI. You will be the supervisor over there. Now, for one room to be managed, probably you are using 3 guys. After the implementation of AI, the AI will take care of work of 2 guys and only 1 will be needed. So, that is what you are apprehending, that 2 guys are gone. No. Your workload will increase. Those 2 guys will be seeing some other thing. The same AI in a different room. AI can't overrule you. It can do monotony, it can do monotonous work, it can... Have you ever seen, you are a young radiographer, have you seen MMR? Where is MMR now? We have come into the digital radiography era, but still radiographers are needed. Similarly, we will see AI also. AI will be helping us. We won't be gone by the use of AI. So, be tech savvy, learn to accept all those advancements which are coming your way. You understand? I hope I am clear.
Thank you, sir.
Definitely there is a huge doubt among all of us whether this after this AI, whether this we are going to sit there or we are going to get out of the professions. Any questions, any doubt, I request once again, you can ask from the grassroots level, what is AI and is it going to replace you and vacant the podium, auditorium? Any questions from?
See, I'd like to add one more thing. AI and ML are not going to trouble you. The only thing which will trouble is deep learning. And deep learning will not trouble you until unless it has all the quotients of human intelligence, which we are not going to give it to them. The emotion, the sadness, the happiness, the cost of calculation, the calculative power, these things, they are possible in a very, very remote sense. See, a robot cannot love anyone. He cannot hate anyone. Until unless these powers are being given to the system, till then you are safe.
Thank you, Dr. Saab. Now everybody is confirmed that everybody's job is secure. Nobody is going to out. and this always the artificial intelligence comes by the natural intelligence. So everybody will be there in the auditorium and everybody will be there in the stage. Thank you once again, very nice lecture.
Thank you so much, sir. I'm really honored.
To present the certificate and the memento to Dr. Balani. Then I request Dr. Sikumar sir to present the memento to Dr. N.K. Singh. I request to Dr. Sikumar sir to present the memento to Dr. N.K. Singh. Now I request Dr. Saurabh Bhai to present the memento to Dr. Sikumar sir. The lunch break is just after 5 to 10 minutes. After that, the sessions are at 3 p.m. The first session is going to be held as a radiology of stroke and its model management by Dr. Apritam Chatterjee. Unfortunately, we will not start in, it was the first session today, but we could not start it. Rubo? Sure. Kindly be present at particular time at 3 p.m. The second session in the afternoon at 3:40. The session is the molecular imaging and therapeutic targeting of art and science of thanatosis. It will be presented by Dr. Adil Adnan, is the nuclear MBBS MD in nuclear medicine, and subsequently the next session will be the patient safety beyond radiation protection measures. It will be presented by Dr. Sumit Sharma, MD Radiodiagnosis, PDF Oncoimaging and Interventional Consultant Radiology in ECG, SCG Eco Cancer Center, Calcutta. So there will be very interesting topics. All are requested. After the lunch, please come to the auditorium, take your seats. After that, at 17 hours, we'll start our very interesting e-poster competition. Our delegate radiographers, those who have participated, please give their presentation to the computer. We'll set it now and it will be start at 5 p.m. And the guideline already has been given to all. It will be a 5 minutes presentation with 2 minutes question answer session. And judge will be there. They will give their marks and the award is the first, second, third prize to all the competitors. So this is the second session scientific program. Now those who have not taken photograph for the cup which is being done in the outside, please go there and take a photo snap for the cup. And after that evening session we will have a cultural program at South Institute, VNR Garden Ridge. After this program, all are requested and also cordially invited to attend the cultural program followed by a dinner. Thank you.
Begins. This session begins with the topic stroke and risk management, and the speaker is very dynamic person, Dr. Apritam Chatterjee. He has passed MBBS from Medical College Kolkata, MD Medicine from IGPMR Kolkata, DA Neurology from Bombay Institute of Neurosciences Kolkata. He has done 2 years of STNI fellowship in interventional neurology from Medanta, Goa. He has performed more than 1500 interventional cases. He has a large number of patent publications at national and international journals. And at present working as senior neurologist, stroke in charge, AMRI Hospital, Kolkata. So,
thank you, sir.
Over to you.
Thank you, sir, for the kind introduction. Yeah, so My presentation will be more of radiological images, more of case scenarios, and as we move on with our cases, which may be good or which may be bad, we will gradually discuss about the various ways how we diagnose acute large vessel strokes in day-to-day practice. So, to start with, we all know this, that stroke basically is either ischemic roughly or hemorrhagic type, which may have various subtypes, and one part is to manage the acute stroke, which is what we are concerned about right now. The other part is why did the stroke happen? So, three questions I always ask my patients to ask the doctor treating a stroke. Number one, doctor, where is my lesion? Number two, what is the type of lesion? Is it an ischemic or a hemorrhagic one? And number three, why did the lesion happen? So if these three answers, morbidity caused huge mortality issue. Why we are talking about stroke right now. Now it's never a one-man person approach, it's always a team approach where only an interventionist is a part of the whole team. We have a neurologist, neuroanesthetist, critical care and neurosurgery, and of course a very good active rehab team has to be there. So to spot a stroke, we know that we all go by the fast symptoms where facial deviation, arm or limb weakness, speech disturbance is important. However, added to this are the BEL. B stands for acute balance problem, E stands for acute vision problem, A stands for loss of consciousness. So anything presenting with these symptoms, these 6 symptoms in the emergency will be coded as an acute brain attack or a stroke by the emergency team, and this code will be activated. Now whenever this code is activated, the patient stands within 4.5 hours and it satisfies the eligibility criteria. Thrombolysis is offered, which is an IV drug, which is a clot buster. Initially we used altiplase, nowadays we are moved to more of phenetiplase because of this specificity issue. Just one case to summarize the IV thrombolysis, and then I will move straight away to the thrombectomy part. So this is a 40-year-old gentleman, comes to us with a left hemiparesis with a facial deviation and a swelling of speech. Initial CT scan is one interesting radiological feature in such CT scan which you can identify as the MCA inside. Whenever you have the contralateral side paretic and the opposite side having this sort of a side, it means there is a large vessel occlusion in MCA. Whatever hypertension we are seeing is a clot burden. So it's a huge clot, and whenever we see such a picture, we know thrombolysis, the chance of working is 25%. So thrombolysis may not open this patient, and we may require thrombectomy. So it's a bad case, it may go to a worse prognosis. Now, in our protocol, we always ask our emergency physicians to get adapted with the aspect scoring, which is another radiological scoring. We all know that basically there is something called as cortical or ganglionic level, something called as supraganglionic level, where we have 10 such areas, M1, M2, M3 in the cortex, M4, M5, M6, and caudate, one in the lentiform, one in the internal capsule. So total 10 areas, 1 point each. Every place you have an infarct or an ischemia, you deduct 1 point. Lesser the score, worse the prognosis, worse the outcome, and the more chance of a large vessel. So basically, it is acceptable that if it is 8 or above, it is usually a good aspect. More than 6, moderate aspect. More than 5, moderate aspect. Less than 5 or is a bad aspect or a poor aspect score, which signifies already some amount of damage has occurred prior to your treatment. So basically, if you have a good CT scan reading ability in the emergency, you do not need much of investigations actually. So in this patient, we saw a CT scan, you go back to the CT. You move back to the CT and you see I have changed the window of the CT as well. So it is more sort of an ischemic window where I want to see which are the areas already damaged. And it's a plain CT scan where you can actually see a clot. So many informations I gathered from just this CT. Number one, it is not a bad aspect. Number two, there is a large vessel and a huge clot burden. Having said this, since we have the advantage of a CT angio, we go immediately for the CT angio, not an MRI. Patient coming within 6 hours, no need of an MRI. We go for a CT angio.
Now the house is open to question. Any question, please?
there is 3 stages. One is necrotic, which is not recoverable, and one is prone to necrosis, and another is good cells. And how can we save the prone to necrotic cell?
So that is what we have shown. That is what we call initially used to call the penumbra. So that is what we all showed about. So whatever we are fighting is to save the prone to ischemic zone, which is called the penumbra. And how do you identify that? If you have so there are 3 or 4 ways to identify. If you ask me as a radiology, how is the best technique to identify? Very easy tool is a CT perfusion in anterior circulation. In posterior circulation, CT perfusion may or may not help. Number 2, if CT perfusion is not available in a setup, like in majority of the setups which I perform, you can get a DWI flare mismatch, you are still having a lot of penumbra. But actually, it is not always true. Why? A flare loss only tells you that the time window is more than 5 hours. It doesn't guarantee you that that opening the brain or revascularizing it won't save the tissue. So it doesn't guarantee you. Nowhere it's written. Number 3, if you see a huge NIHS, so a patient is having a large deficit with a good CT, you don't have a CT angio, you don't have an MRI, you have a dense plagia, so complete loss of movement, either in the left side or the right side, you have an aphasia, you have a gaze preference, the patient is looking at one side, or along with this patient is having a seizure. So these are the 4 features I always teach my emergency physicians. If the patient is having an acute onset stroke symptom with these clinical features and the patient is having a good CT scan, that means a good aspects, think that you are having a clinical radiological mismatch, you are having a huge penumbra, just either do a CT angio or straight take to the cath lab after thrombolysis if you have an advantage and open the vessel up. So now, this was what I used to tell previously. Now we are more aggressive. We are more aggressive. Why? If the patient is having a bad aspect, patient is having a formed infarct, that is what I said, the tension trial says already formed infarct, but still the motor strip is preserved. The motor strip is preserved, you are having say temporal infarct or say subfrontal infarct, but the motor cortex is still preserved. Give it a chance. अटेंडेंट को काउंसलिंग करिए, उसको बोलिए कि देखिए ऐसा है, अगर नहीं खोलेंगे तो पक्का या डेथ है या वेजिटेटिव लाइफ है या चांस इज मीक, बट अगर खोलेंगे तो चांस ऑफ लाइफ मे बी देयर. इट हैज हैपेंड, आई हैव शोन इन रिपीटेड केसेस. Not all cases do well, but you counsel that, take the attendance consent if they are ready to take that risk, because otherwise there is no value of giving a medical therapy to this patient. So, prone to ischemic zone, ये हम पहले बात करते थे. अभी हम बात कर रहे हैं कि भैया CT एंजियो करो, अगर 12 घंटे तक एंटीरियर सर्कुलेशन है, अगर लार्ज वेसल है इसे खोल दो. अगर ऑलरेडी इन्फार्क्ट बहुत हो चुका है, अटेंडेंट को बोल दो कि भैया चांस कम है लेकिन यही बेस्ट थेरेपी है, हम कर सकते हैं. We should give a chance. That's it. Simple approach. सब केसेस ठीक नहीं होंगे, लेकिन 80% भी होंगे तो काफी है.
Another question is, you know that drug addicted patients are prone to brain stroke.
Very nice question.
Why?
Yeah. So I could demonstrate this case. I had one case. So there is one patient who came to me from Northeast recently, now Amis holiday. He had a young guy, around 35 maybe. So recurrent right-sided weakness and aphasia, recurrent. When we did as per protocol, when we did a CT angio, there was M1 occlusion, and we immediately took for DSA. The DSA showed that very brisk collaterals, and when we did the DSA, the patient already had an improvement. So it was a stuttering sort of a stroke. So what we did is, so patient is having a brisk collateral, and we did a CT contrast, MR vessel wall contrast. So in those cases, if you do a MR vessel wall contrast, you may find he had a history of cannabis, huge cannabis addict in Northeast, and his vessel wall showed enhancement around the stenotic area, which was suggestive of sort of a vasculitis. So in drug addiction, there are some drug abuses which cause intracranial vasculitis. These patients may also have sudden onset headache, intracranial dissections presenting with rupture and bleed. So this patient I am talking about, I did not intervene, I did not open up, because I know when I try to balloon angioplasty this patient, chance of bleed is more. But even without doing that, patient had an SH. Patient survived, did well, and still now is not having any symptoms. There are two reasons. I added a steroid, thinking it's a vasculitis. It did very well for him. Number two, I did not intervene. And number three, we just raised the BP. We stopped all antihypertensive medication because he is dependent on the collaterals, and we stopped the cannabis intake. So these are the few things you can take care of.
Problem we are facing here. I am usually here in the southwestern area. So we got some patient in early stroke with the disabled ganglios crying, insular ribbon sign. But the problem is, one, sometimes patient don't give consent for sending outside. And second is the time between the referral and reaching to your institute or our tie-up center. So the total time may be, like patient already come at 7, 8 or 14 hours, and due to some referral time it will already goes beyond the 15 or 20 hours. So that is a real-time problem. And another thing is, another thing I want to know from you, that if the already infarct is set up with, say, the HU value already it is 15, 20 in 15 hours already. So there is no question of anything further with intervention. And what is the maximum extent?
So I take the last question first, because that is the most important medical related question. So number one, already formed infarct. So how much is the formed infarct? Is it, that is what I said, is it involving the motor cortex? It is already involving the huge frontal area. So if you have the left side, we know that left side brain and right side brain, the prognosis is different. If it's a right side brain, even if he has a significant amount of infarct, the chance of him surviving and doing well is better. In left side brain, if he has a significant infarct, it is worse. Why? Because even if he survives, the chance of him getting vegetative is more, because he will be aphakic. He will not comply with your rehab. Number one. Number two, so this is one thing we always think before going in. Number two is, how much is the amount of brain damage? Is it less? Is it sparing the motor cortex? I can show you multiple cases where I took up only based on CT. So, बीच में ऐसा हुआ था sir कि I was skipping CT angio. Even today's case I skipped CT angio. Just did a CT and just take to cath lab straight. So in CT में ही पता चल जाता है कि large vessel है. If the amount of deformed infarct is less and to less significant area, say temporal is infarcted and your frontal is preserved and your motor strip is preserved, go for it. Tension trial has eased it up. It has shown by evidence. So if suppose the patient rebleed, patient can have a reperfusion bleed, patient can go to court of law, you can show, sir, we have evidence, tension trial, that within 12 hours in anterior circulation stroke, if it's a large vessel, even with formed infarct, it is very, very well established now that we should give vessel opening a chance. Of course, the prognosis will depend on the amount of tissue already infarcted. So always, on the practical aspect, we take in writing from the patient, relatives. Patient may not do well, but if you ask me evidence, I will always be in favor.
And if there is no direct or indirect, we should do and tell him later.
We should always do a breast thrombolysis and we should send the patient. Having shared that, in the meantime, I am here since last 2.5 years in Kolkata, before that we were in Medanta. So last 1 year I was more towards direct thrombectomy, radiologists these days are going towards more thrombectomy approach, direct to cath lab route. There are 3 trials in this. We did very well with that, but there are few cases when you can't open the clot. There are some clots that we don't open. 4 passes, 5 passes, we fail, patient dies. So if we can't open up, then if you lyse it before, the clot softens. So it's always a sort of a mixed clot. So it can be a red thrombus, it can be a white thrombus, or it can be a combination. If the patient gives you the opportunity to lyse, give it a lysis. But there are also cases that I have done a lysis, I have opened the vessel up immediately by a single pass, patient does immediate, aphasia patient improves, removes hand, talks to the relative, goes back home, within 1 hour he has a tenecteplase induced bleed. However, the patient survives, but there is a huge drop in NIHs. The cost increases, all these issues do come. But you can't help it, that is the protocol right now, breach protocol.
Okay, thank you very much.
Moya is again a subset of patients where we have to be cautious about 2 things. Number one, you do a DSA because the EDAMS and the ST&CA bypass does very well. So you know the collaterals. We do a SPECT, we do a SPECT.
In fact, this is not a course. This is not a. This is a real life experience with me. And how scientific seminars and semi programs empowers everybody is an example with me. My daughter now she is 25 years. She is now studying doing masters in law in one of the reputed institutions of India. At the age of 3 years, accidentally she had some headache and X-ray was done. Some problem was detected, and it was 22 years back. It was the CT was not available where I was posted. It took time to do a CT scan. On CT scan, the diagnosis was not given. After 3 days, from various consultations, she was diagnosed with a case of vein of Galen malformations. It was I am a gynecologist. I didn't know about vein of Galen malformation at that time, and it was a very dangerous conditions, and naturally doctor told that she would die at any time. I consulted several neurologists, neurosurgeons, and they told that we can do operations, but the mortality is 90%. For the subsequent 7-8 months, I forget all my topic, my subject, and studied about the neurology and neurosurgery, and about the and I came to know that the radiologist will be the god. I consulted the neurologist of AIMS, and he told that it will take 6 to 8 months before he can be given appointment. Then by God's grace, I contacted Dr. Gupta, A.P. Gupta from Sri Chitra Institute of Medical Sciences at Trivandrum, and he gave a time. He is interventional radiologist, and he gave a time. She was operated. She was all investigation like DSA, everything was done. It was a large, massive vein of Galen malformations. And she was undergot operations, interventional radiology operations done. She was given methamphetamine glue, and she was discharged after 4 or 5 days. And she is got by touch wood, she is doing well in studies also. So it is one of the miracles, and I think that the medical science is improving, and you are the caterpillars, you are the pioneers of development. Whatever the development in medical science happens, it is because of the radiological intervention only in the future. So my sincere gratitude to all your community. In fact, I told the JB, when he was my colleague in Kharagpur, you do your interventional radiologist, and I think you will be one of the best interventionalists at this. Thank you very much.
Thank you, Dr. Putin. Certificate and memento to the guest speaker, Dr. Putin Chatterjee.
ওখান থেকে সরো
Thank you, Dr. Putin Chatterjee, for your valuable and very and therapeutic targeting the art of science of therapeutics. Dr. Adil Adnan is a nuclear medicine MBBS MD from Medical Super Specialty Hospital. I request Dr. Sumit Sharma, MD Radiology, to be chairing the session, and Dr. P.K. Majumdar. Please go to the dais and chair the session.
I know Dr. Adil, I was at a conference of Medica, and a few days back we had a very great, we call all the doctors from all over the corporates in the for the cancer hospital group. So I was there, I know you by face, I have attended recently. So very welcome in our hospital. So today, so may I introduce Dr. No. Yeah, just excuse me, Adil.
No problem, sir. If you permit, I can start with
Dr. Adil Adnan is a seasoned nuclear medicine physician, currently serving as the head of the Department of Nuclear Medical Super Specialty Hospital, Kolkata. His journey in the field of nuclear medicine began after he completed his post-graduation at the Radiation Medicine Center, RMC BARC, within the esteemed Tata Memorial Hospital, Mumbai. Driven by the vision of advanced radionuclide therapeutics in the Eastern India, he relocated to Kolkata. Dr. Adnan's contribution to the field are remarkable. He is a pioneer in targeted radionuclide therapy, introducing innovative treatments for the conditions like prostate cancer, neuroendocrine cancer, pheochromocytoma, paraganglioma, and more. So there are very long contribution of Adil in the field of nuclear medicine. By the way, I am also a follow-up case of paraganglioma, of carotid body and underwent surgery in Hyderabad. So nice to introduce Adil in this forum. I think you will all learn. Please Adil, carry on.
Thank you, sir. Thank you so much for the kind introduction. And am I audible still the back? Good afternoon, everyone. So let me introduce the topic to you. It is the molecular imaging and therapeutic targeting, the art and science of theranostics. Nuclear medicine, this question, what is nuclear medicine, is I am encountering since my residency days by my colleagues, my friends. The first thing they, after knowing my grant, they used to ask what nuclear medicine is and what you do there. So nuclear medicine basically is a science which deals with the unsealed radionuclide for various diagnostic and therapeutic applications. Why I use the word unsealed? Because it is the sealed radioisotopes and radionuclide are used in the radiotherapy. When we give external beam radiotherapy to the patients, those are unsealed radioisotopes. Radioactive treatment or diagnosis deals with a radioactive decay. What happens in a radioactive decay is few rays like alpha, beta and gamma, those are emitted and those are used and harvested for medical purposes. Now coming on to gamma radiation or the X-rays, that is very common and we all know about it, is it has the most penetrating power, deposits less energy, and it is used in imaging of the condition or the disease. Whereas those beta and alpha radiations, those are very less or relatively less penetrating than the gamma. They deposit more of the energies or most of the energies along their path and hence are used as a therapeutic radioisotopes. Now, an intriguing concept that has come up to combine both these things, the ability to diagnose and identify the molecular targets and then use them for the therapeutic targeting is what is called as the theranostics, which is a hybrid word, which means that, and for this is a schematic representation here where the diagnostics is used by the MRI, PET and SPECT/CT, the fluorescence, and then there are various therapeutics or therapies directed to those receptors or the gene that has been identified as the offending agents.
Now this is the presentation, pictorial representation or practical I will say, wherein this is the baseline PET CT scan of a prostate cancer patient, where we are seeing all these areas. Those are metastatic areas. These are red and red areas are metastatic areas in the body. With this PET scan, we have mapped the disease burden, the tumor burden, the metastatic burden inside the body, and followed by these, the two planar images are this is the first post-therapy anterior and posterior images. This is the second post-therapy anterior and posterior images, followed by this is the PET scan after 3 months of the second PSMA therapy. What we can see from the first to the last when we transition, we see that most of the disease burden it has gone. So we have treated what we saw, and now we are seeing what we have treated. Now coming on to the very common thing, the theranostics in thyroid cancer. It is of historic importance. Like nuclear medicine, the therapeutics in nuclear medicine started with the treatment of thyroid condition, be it a benign or a malignant. The radioactive iodine was historically used and is today the best possible treatment for differentiated thyroid cancer. Is a SPECT CT scanner, where this is a hybrid machine which has a detector. These two, I don't know if you can see, detected the thyroid cancer also in lab. The risk of permanent damage to the vision. Now, till now we were knowing that there is a patient with off follicular dividing scan, and this was the scan at the baseline after had already known about, and then this is the uptake in the neck that was there. This is the residual thyroid gland after surgery, rather tissue after surgery, and these are it was localized to the area of clivus, causing destruction of the clivus and abutting the optic chiasma. And this is the first panel which shows the pre-radioactive iodine therapy image, and this is the post-radioactive iodine SPECT CT scan. Coming back to the previous slide, we see when we have treated with 2 cycles, these all are gone. There is a decrease in the uptake. You see the star artifact which is showing the excessive amount of radioactive iodine uptake, which was sent to me for LU-PSMA therapy after progressing on enzalutamide therapy. So this is PET CT before enzalutamide. After a few months of enzalutamide, PSMA PET CT showed significant progression of the disease. We treated him with 2 cycles of LU-PSMA. At this time, the PSA was around 80, and after 2 cycles, just before the 3rd cycle, so 8 months of lutetium therapy, the patient was very much relieved. There is a near complete response in this case. PSMA came down to around 9. PSA came down to around 9. And this is the case of alpha therapy. Now it is a new kid of the block in prostate cancer treatment. The alpha was earlier used for treating just the bone pain in prostate, when radium was used to treat the pain due to prostate cancer, bone pain due to prostate cancer. Because that time So this was the baseline scan where we can see each and every bone of the body was involved. The man was extremely involved. The patient was anemic. He had a hemoglobin of around 7. We gave 2 units of blood transfusion, made the hemoglobin to 10, and we took the patient straight away for alpha therapy. He also had cardiac comorbidities, was not offered any chemotherapy or abiraterone, which are cardiotoxic. So we have directly treated, because of this bone predominant disease, we have not considered the patient for lutetium therapy. We have straight away taken him for alpha. The advantage of alpha is it has got least penetrating power, so it will not cause damage to the bone marrow much, and the patient's hematological profile will be preserved. So these are the two post-therapy scans after first and second cycle of PSMA, alpha PSMA therapy, and this is after the second cycle of alpha PSMA therapy, where you can see all this has resolved and there is a complete resolution after third cycle. So theranostics using CD20. CD20 are the markers which are mostly expressed in non-Hodgkin's lymphoma, B-cell non-Hodgkin's lymphoma. So this is a PET scan in a lymphoma patient who has relapsed after rituximab-based chemotherapy. These are the lymph nodes and the axillary lymph nodes which are showing MPT uptake bilaterally. We did a scan using iodine labeled rituximab, radioactive iodine labeled rituximab, which is on the other side of the panel, and these uptake, these are concentrating rituximab, which identifies and binds to CD20. So we have mapped the CD20 cells, CD20 markers positive, CD20 positive cells here with the help of this rituximab, and the patient will then get radioiodine labeled rituximab therapy. Now another very novel tracer that has come up is to target the tumor microenvironment. Now these days this tumor microenvironment is creating a lot of buzz. We see when the cellularity and the stromal component, if we analyze, there is about 15 to 20% of cells which are there in the tumors, and rest of them is stroma, that is called as the tumor microenvironment, which is composed of the fibroblasts, the cytokines, the growth factors, those blood vessels and all. And there is a specific type of fibroblast which is called as cancer-associated fibroblasts, which are myofibroblasts. And these myofibroblasts expresses fibroblast activation protein. So these are the white ones are the tumor cells here, and these are the growth factors. The spindle shape is the myofibroblast here, and on those small ball-like structures, spherical structures, are the fibroblast activated protein receptors. Now these are rather than what all theranostics we have seen, those are directed against the cell. Be it a sodium iodide inhibitor which is on the cell surface, be it a somatostatin receptor or a prostate-specific membrane antigen which is on the cell. But here, what we are targeting is the tumor microenvironment or the stroma, which is not the cell. And hence, it has got uptake in various types of cancer. And the 12 cancers which were diagnosed or detected by this is, and this I have separated it in a group of 4 for
like to like.
Radioiodine causes thyrotoxicosis.
Radioiodine?
Yes.
Yes, there are times when we give radioactive iodine in a benign patient, there are chances of thyrotoxicosis because of cell damage. Those thyroid hormones are there in the thyroid follicle cells, and then they rupture because of this radiation-related damage. Those cells, those stored hormones can spill into the blood circulation and cause thyrotoxicosis. So what we do is, before taking the patient for radioiodine treatment, we make the patient near to euthyroid, and in that we see the free T4 levels. If free T4 levels are less or it has come down to normal, then we take the patient for radioactive iodine treatment, thereby minimizing the chances of thyroid storm or the thyrotoxicosis.
Wonderful. Hello.
Presentation. The nuclear medicine, it is a booming science in the imaging science, no? So, especially it is a conference of the radiographers. I want to say a few words for the radiographers. Those who are handling the radiation handling the working the radiation unit. Suppose in the X-ray, digital X-ray, CT, any nuclear medicine, the hybrid system, it is a, the PET CT where radioisotopes are used. We are using radioisotopes, it has some time constant to use the isotope within the time. So handling this system and the detecting the lesion, that is very important. It is not the work of the radiologist all the time, but the informing the detected pathology to the radiologist, it is also your duty. Okay, so the knowing the image, the entire world is now image-based clinical practice is there. So knowing the image, now image speaks about the pathology. So everybody should know the language of the image, everybody should know the message of the image. That's why I have interrupted. So everybody has the contribution to identify the image. So image has lots of variation in the form of X-ray, USG, CT, PET CT. So knowing the image is very important. Thank you, Arvind.
Thank you so much.
Thank you so much, sir. Now I request Dr. Majumdar sir, please give the certificate. Dr. Sumit Sharma sir to give.
Sir. Sir, I guess Sumit sir. Thank you, sir.
Now the next beyond radiation protection measures, it will be the scientific session will be done by Dr. Sumit Sharma, MD, Radiodiagnosis, PDF Onco Imaging and Interventions, Consultant Radiologist, SCD Eco Cancer Center. The session will be chaired by Dr. S.K. Mishra, CMS Chakadharpur, and Dr. Saurav Bara, DMR Radiology Central Hospital, Kharagpur. Central Hospital, Garden Hills.
Dr. Sumit Sharma, the renowned international radiologist, after being post-graduations, he had a stint of 2.5 years fellowship at Tata Memorial Center and Tata Memorial Hospital in Mumbai. Till now, he has done more than 5,000 interventional radiology procedures, spending 5.5 years. He has a lot of publications in national and international journals with a highly skilled performing imaging guided biopsies, guided drainage, and cancer ablations. Apart from interventional procedures, he had special interest in thoracic imaging, especially interstitial lungs disease. He is a life member of different national and international Society of Interventional Radiologists. In his short career, Dr. Sumit has helped to develop the radiology department, especially interventional radiology department, in different hospitals of government of Assam, Tamil Nadu and Andaman. Recently, he has established a state-of-the-art hospital, Apollo Clinic at Port Blair. Congratulations, doctors. His patients recognize him for his immaculate interventional skills. Not only that, but for his post-operative and palliative care. I welcome once again Dr. Sumit Sharma for his presentation. Now the stage is open to you.
Thank you, sir. So, today I have decided to step out of my comfort zone. It is not intervention that we are going to talk about. It is about patient safety beyond radiation protection measures that should appeal to all of us. If you are going to continue about RFA, stays and care, this might not be sufficient time enough for me. But if we are talking about patient safety, I think this should fit the bill. So this year we are celebrating Radiology November 8th as the Radiographer and Radiology Day. And the reason being because a gentleman from Germany decided that the radiation can cause some kind of X-rays can cause these kind of images, So this was the first röntgenogram which was taken and which is known as X-ray. This was the X-ray of his wife and the ring is seen there. And this year we are celebrating the patient safety, so which is why I chose this topic. So I'll be talking about all this and just touching upon all these topics. These are quite important. I think we should all be checking this out. Now X-ray is the tool that we have got to make sure that there is no excessive radiation usage. Apart from that, awareness and care for the patient safety is of paramount importance. What are the aims and objective of this talk? We have to make sure that there is protection from direct harm arising from the techniques and technologies used for the patients. We are trying to help them after all. Ensuring physical and physiological well-being of patients while under care for us. Maintaining the highest possible quality of service that we can provide for these patients. And protecting our own staff to ensure they can deliver safe services. What is radiation protection? I think we are all aware of it, but under the umbrella of Eurosafe Imaging, ESR and EFRS have made strong commitments to all aspects. So there are three main principles which we have to discuss most of the time before we take up a case for imaging. Justification, optimization, that is dose optimization, and magnitude of potential exposures. Now which should be as low as reasonably achievable. There are 3 points over here that has to be discussed. Justification, to do as much good as possible with as low radiation dose as much as possible. Optimization, we have to make sure that we choose the right patient, we make sure that we choose the right limb, we make sure that we give them the right kind of dosage and a dose reference levels. Now there is a Euclid trial. Now this Euclid trial was performed in Europe and they made sure that now we can actually adjust the dosage according to the limbs and also body surface area. So this trial got completed in 2022. Dose incidents. Now this is something that as radiologists and radiographers we have to avoid. This is medical exposure that is significantly different from the medical exposure intended for the given purpose. So we have to make sure that we do the appropriate thing. This is ICRP dose recommendations. We are all aware of it. Effective dosage, anything 20 millisievert per year, averaged over defined 5 years. This is not a single year period. We have to average it out for a period of 5 years and make sure that the dosage is not touching up to that level. As far as intervention is concerned, I don't think there is much that we can do about it. We are anyways getting exposed a lot. Yes, protection measures are there, but we are having to talk about apart from what radiation protection we can do for patients. Some more things which are useful for us to know is drug and contrast issues. Now, we know that you would have heard the question that I asked to Dr. Adit. It was about whether your radioiodine causes thyrotoxicosis. You are here to help the patient, but if you end up giving the patient some more problem, I don't think you are helping them out. So this is quite important that we know how we are going about our job without harming them. Most importantly, we have 3 types of agents for contrast: iodinated agents, gadolinium based contrast agents, and microbubbles. Microbubbles is not something that is used in India that frequently, not in my center also. So hypersensitivity reactions we can see in all 3 kind of agents. While nephrotoxicity you will see mostly with iodinated agents. Metformin in a case of patient where diabetic in a diabetic and the EGFR is less than 30, so then we have to think of whether to withhold metformin and do the test. In that case, we have to make sure that iodinated contrast might cause a reaction and lactic hyperacidosis. Nephrogenic systemic sclerosis or fibrosis is usually seen in case of gadolinium only. Brain deposition and other kind of organ deposition is not seen in case of iodinated but can be seen in gadolinium.
The question
messages, then we can speak to next session.
Thank you. One thing I wanted to say, sir. So far as the radiation safety is concerned, we are always for a patient benefit. While doing any type of radiology procedures, it may be a X-ray, it may be a CT, it may be a PET CT, whatever the case may be, it is totally patient oriented. We are going to help the patient making the diagnosis and give the appropriate diagnosis to the clinician so that patient will be treated as early as possible and get benefited. Apart from that, because of the patient benefit, we should take safety for yourself. Because as we are doing daily for a prolonged period in the radiation zone, Sir has already briefly described detail how the radiation protection should be taken each and every radiographer. It is one of the most important vital things, as because the hazards of radiation everybody will know. The dangerous hazards in future when the radiation exposure is beyond your protection limit. That's why it is sincere request to all the radiographers, those who are doing in Delhi in your duty places for radiation zone, you should take your sufficient safety protection and you should always use your TLD best to calculate whether the radiation dose is larger, it is insufficient, it has to be calculated and take sufficient action to protect yourself from the radiation effect. That's why this topic is extremely important for each and every, for your safety purpose. And I think Sir has very nicely described all aspects of the radiation protection and safety. Thank you, sir. Thank you.
I just like to add a different angle about the radiation safety. That for the radiographers, the radiography will never abolish. It is always a screening procedure, radiography. Now suppose the HSCT chase, it cannot be a screening procedure for all the patients. So for the safety, the selection of the patient, it is the utmost important. For which patient, which investigation is to be done. Like HSCT temporal bone, HSCT chase, these are the high radiating dose procedure. One HSCT chase equivalent to more than 1,000 of the X-ray. So it cannot be a baseline investigation for all the patients. And here lies the clinician expertization, because they will select the patient for whom after the normal X-ray the HSCT is required or not. I have seen Berasar, Dr. Anindra Bera, that he is admitting a pediatric patient with just a radiograph, diagnosed as a bacterial pneumonia after giving antibiotic for 7 to 10 days, discharge the baby before doing another radiograph. Just 2 radiographs in 10 days or 7 days apart and completely cure the patient. So it should be the approach. So don't do the investigation unnecessarily, it will give you more burden to the patient, nothing else. And radiography will never abolish. Radiography is the screening procedure for all the purpose, always.
Okay. That is why radiation safety says the justification and ALARA principle. Justification is one of the most important for the patient. Have a sufficient justification, and this should be a cost effective and essential for life saving. Otherwise, unnecessary doing lot of investigation, radiological investigation for the patient, it is harm to the patient as well as harm to the person, those who are doing the procedure. That is why it is extremely important to know the procedure to be justified or not, and ALARA principle as low as reasonably possible. जो भी हो, ठीक है. तो अभी now I request Dr. S.K. Mishra sir to give a certificate and memento to our guest speaker, Dr. Have a big hand for this.
Thank you, sir. Sir, able. Record. Thank you, sir.
Now, I have a special announcement. Our radiographer, Mr. Rajiv Kumar from Chakadharpur, he wanted to present a small presentation regarding this safety of a radiographer, safety of a patient, regarding
respected all senior officers, all the delegates, families. मंडल रेल अस्पताल चकधरपुर में, जो कि बहुत ही रिमोट प्लेस है, हमारे डायनेमिक CMS सर डॉक्टर सुब्रत कुमार मिश्रा सर वहाँ पर CMS हैं। तो चकधरपुर जो है वो जो मैसिव सारंडा फॉरेस्ट है उसके बीच में सिचुएटेड है, जो कि टाटा नगर रांची राउरकेला के बीच में वो आता है। महात्मा गांधी जी ने भी इस जगह वो आए थे और उन्होंने एक बुक है जो 3rd क्लास में इंडियन रेलवेज, वो उसमें उन्होंने चकधरपुर का मेंशन किया है। वहाँ पर मिनरल्स के भंडार हैं। ये हमारा चकधरपुर का रेलवे स्टेशन और हमारा हॉस्पिटल है और वहाँ की ये सीनरीज हैं। ये रेलवे अस्पताल है हमारा। सबसे पहले मैं कहना चाहूँगा कि बीइंग ए रेडियोग्राफर हमें जो हमारी जो रेस्पॉन्सिबिलिटीज़ है, हमारी जो ड्यूटीज़ है और हमें जो फेस करना पड़ता है बहुत ही इम्पोर्टेंट है। जब मैं 2008 में ज्वाइन किया था तो वहाँ पर जो एक्सरे रूम था वो बहुत ही पुअर कंडीशन में था। वहाँ पर ना बैठने का चेयर था अच्छे से, ना अच्छा टेबल था, ना सेफ्टी से रिलेटेड कोई लेड लाइनिंग ये डोर्स थे, ना लेड ग्लास था, ना कोई अलग से चैम्बर था। सिर्फ एक हॉल था, उसी में एक्सरे मशीन भी था और उसी में हमें सारे स्टाफ भी रहते थे। उसमें कोई भी सेफ्टी फीचर्स नहीं था। तो जब से CMS सर डॉक्टर मिश्रा सर आए तो उन्होंने देखा कि तो बहुत ही पुअर कंडीशन है एक्सरे रूम का, तो उन्होंने स्पेस चेक किया और आज ये हमारा चैम्बर बनकर तैयार हुआ है। ये हमारा चैम्बर है, हमारा वहाँ डिजिटल रेडियोग्राफी अभी इंस्टॉल हुआ है। ये हमारा चैम्बर है। ये हमने वहाँ पे डिजिटल रेडियोग्राफी ये सिस्टम को इंस्टॉल किया है। यहाँ पे विजिटिंग ये है, पेशेंट के विजिटिंग पार्टीज वहाँ पे वेट कर सकते हैं। तो हमारा मेन कंसर्न है कि हमारा सेफ्टी एंड पेशेंट सेफ्टी। तो हमारा सेफ्टी क्योंकि हम लोग रेडिएशन जोन में काम करते हैं। एक्सरे जो है ना वो इलेक्ट्रोमैग्नेटिक वेव्स है, वो आयोनाइजिंग रेडिएशन है। वो जब हमारे शरीर से गुजरती है तो हमारे एटम्स को आयोनाइज कर देती है और जब रेडिकल्स होते हैं मतलब एटम आयोनाइज होता है तो उनसे हमारे शरीर को बहुत ही नुकसान होता है। उसके लिए भारत सरकार ने 1962 में एक एक्ट बनाया था, एटॉमिक एनर्जी एक्ट। तो इसलिए बनाया गया था कि वो चूंकि एक्सरेज हो, गामा रेज हो, बीटा रेज हो, अल्फा रेज हो या कोई भी आयोनाइजिंग रेडिएशन हो, वो जब किसी ह्यूमन बॉडीज में उसका इफेक्ट बहुत ही ज़्यादा होता है तो वो जब वो खुले में जाएंगे तो वो बहुत ज़्यादा नुकसान करेंगे। इसके लिए उन्होंने एक 1983 में एक एटॉमिक एनर्जी रेगुलेटरी बोर्ड बनाया। तो उसमें सारा जो हमारा गाइडलाइंस है उसमें दिया हुआ है कि हमारा एक्सरे रूम, चूँकि हम लोग रेडियोग्राफर्स हैं, हमारा कंसर्न एक्सरे रूम से है, हमारा CT स्कैनिंग से हमारा कंसर्न है। तो वहाँ पर वो कैसा होना चाहिए उसके लिए एक गाइडलाइंस ARB द्वारा बनाया गया है कि उसमें जो हमारा रूम है वो जैसे डोर है वो लेड लाइन होना चाहिए, लेड सीट से वो डोर कवर होना चाहिए। हमारे जो विंडोज है या तो 2 मीटर से ऊपर होना चाहिए विंडोज, या फिर अगर विंडोज नीचे हैं तो उसमें लेड ग्लास होना चाहिए, या फिर वो विंडो क्लोज होना चाहिए, विंडो नहीं होना चाहिए, ताकि वो जो एक्सरेज है वो बाहर ना जाने पाए। साथ ही हमारा जो जहाँ एक्सरे हम करते हैं वहाँ एक सेपरेट रूम होना चाहिए रेडियोग्राफर्स के लिए। सेपरेट रूम नहीं रहने से अगर सेम रूम में आप एक्सरे करेंगे तो फिर आपको रेडिएशन लगेगा और फिर आपको काफ़ी नुकसान हो सकता है, आपको अपनी फैमिली के लिए भी और पेशेंट पार्टी के लिए, पेशेंट पार्टीज के फैमिली के लिए भी वो काफ़ी नुकसानदेह हो सकता है। तो इसके लिए ARB ने बहुत सारे गाइडलाइंस बनाए हैं
उसी आधार पर जैसे हमारा जो एक्सरे रूम का वॉल होना चाहिए वो 15 इंच का मोटाई होना चाहिए, 10 to 15 इंच मोटा होना चाहिए। सारे डोर्स जितने भी डोर्स हैं वो लेड लाइन होना चाहिए, लेड सीट से वो प्रोटेक्टेड होना चाहिए। हमारा TLD बैच जरूर होना चाहिए। TLD बैच होने से हम जो रेडिएशन को एब्जॉर्ब करते हैं वो रीड होता है हर एक ट्राइमेस्टर 3 महीने में वो रिपोर्टिंग के लिए जाता है। मैं शुरुआत में जब वहाँ ज्वाइन किया था तो मुझे रेडिएशन लग गया था, 1-2 बार जब रिपोर्ट आया था तो रेडिएशन लग गया था मुझे, तो उससे बहुत ज़्यादा हैजार्डस हो सकता है। तो बहुत सर इसमें
सारा चीज़ बहुत अच्छा बताया, काफ़ी सारी चीज़ें। एक एक्सपीरियंस शेयर करूँगा आप लोगों से। ये PCPNDT एक्ट के बारे में जब हम लोग भी मैंने 2001 में ज्वाइन किया था सर, तो उस एक्ट के बारे में बहुत सारी जानकारी है। एक चीज़ धीरे धीरे करके अब तो काफ़ी धीरे जानकारी हो गई है। जहाँ जहाँ रिस्पॉन्स सेंटर है वो सब, और खासतौर पर राजस्थान और हरियाणा में आप जान रहे हो बहुत सारी चीज़ें होती हैं। जी सर। तो अभी आपने बात की थी, हम इसको कंडेम तो कर सकते हैं बट उसको सेल नहीं कर सकते। तो अब हमारी मशीन जब खराब हुई, हमने नई मशीन ले ली जी, तब मशीन के लिए भी वो पूछते हैं क्या मशीन की कंडीशन है क्या नहीं है। जी जी। तो हमने कह दिया कि ये मशीन खराब है और इसको हम कंडेम कर रहे हैं। जी सर। जब हमने उनको जवाब भेजा तो उन्होंने कहा कि नहीं आप कंडेम नहीं कर सकते इसको। जी। हमने कहा ऐसा तो कोई प्रोसेस नहीं है, खराब मशीन हो गई अब कंडेम कर रहे हैं, क्या दिक्कत है आपको। जी जी। तब उन्होंने गवर्नमेंट बढ़ी, वो भी हम भी गवर्नमेंट बढ़ी जी, तो फिर उन्होंने स्टेट गवर्नमेंट को अपने उनको चिट्ठी लिखी कि क्या इसको कंडेम किया जा सकता है, ये कंडेमनेशन वर्ड PCPNDT रूल में कहीं है नहीं जी जी। और हमारी अल्ट्रासाउंड मशीन रेलवे से रेडेड नहीं होती, PCPNDT से रेडेड होती है। फिर उन्होंने वापस में चिट्ठी लिखा नहीं आप कंडेम नहीं कर सकते इसको, बिकॉज द कंडेमनेशन वर्ड इज नॉट देयर इन PCPNDT जी। अब आप इसको केवल सील करा सकते हो जी, डू एट योर ओन बेसिस की मशीन खराब है, जो कुछ भी करना आप अपने टाइम में कर लो, बट डोंट यूज द वर्ड कंडेमनेशन, इसको आप सील करवा लो। और हमने अभी वही लिखा है कि आप सील करवा करके मेरे खत्म करो इसको, राइट।
Thank you sir for nice information. This actually these things are not known to us. So and thank you Rajiv. You nicely presented the topic in what is going on in the Chakadharpur Railway Hospital, and I should say Dr. Subrat Kumar Misra, Chief Medical Superintendent and Gynecologist, he should say something. He should say something regarding this.
पहले मैं जब आया था चक्रधरपुर में, मेजोरिटी लोग काम नहीं कर रहे थे लेकिन मैं थोड़ा बहुत काम किया, लेकिन अभी सब लोग काम कर रहे हैं, मैं अकेला घूम रहा हूँ।
This is the beauty of the leadership. This is the beauty of leadership. I am privileged and I am proud that I have done along with Dr. S.K. Misra sir, 3 to 4 years in Kharagpur division. I have known personally Dr. S.K. Misra sir, how he is a dynamic person, how he is an attitude and constructive way to develop the hospital anywhere. He either Kharagpur or Chakadharpur, anywhere. Whenever he goes anywhere, he wants to develop the hospital in a large way, and now this CKP is glowing like anything. And I should say this credit goes to Dr. S.K. Misra sir. Thank you sir. And his guidance, Rajiv is going to present a very nice presentation regarding the hospital safety and the. Thank you sir. Now it is the time.
पर्सनालिटी डेवलपमेंट के में सर इनका बहुत रोल है, कोई बोलना नहीं चाह रहे थे कुछ नहीं सर, वो बोलवाते हैं सर, लीडर का क्वालिटी है।
Now it is the time for a e-poster competition. Approximately 6 radiographers has participated. We are expecting more, but anyhow 6 radiographers participated, and already the guideline which we have already sent initially. What are the guidelines by which you can present your e-poster, the time limit, the slide limit, the topic structure, everything already mentioned in the guideline. Again I am saying the guideline for the e-poster presentation. It should be within 5 minutes. and plus 2 minutes for discussion or question answering. And the slide, maximum slide 10 slides, not more than that. And you have to explain your case, whatever you are supposed to present in detail. And there will be 2 minutes question answer session, and marking will be done accordingly.
So the judge for this competition is our pediatrician ACSD sir, Dr. A. Veda, Anindya Veda, and Dr. J. Shah. Sir, please goes to the judge. And before starting, there will be a
ও পড়তে পারবে না, পড়ে দিন।
So you will present first. Okay, please come front. Next. Subrata Pal. You will be second. Present. Sit here. I will call you. Sit side by side. Sequential, yeah? Subrata Pal, go there. Neeraj Pandey. Next.
SK Basu. Suparnakanti Basu.
চেঞ্জ হয়েছে প্রদীপ দা, প্রদীপ প্রামাণিক।
Okay, you go there.
আচ্ছা, প্রদীপ প্রামাণিক।
Okay, last.
कृष्णेश दास।
The last one.
और कोई बचा है क्या? एहसान खान, last but not the least.
அனைவருக்கும் வணக்கம். குட் ஈவினிங் ஒன் அண்ட் ஆல் பிரசன்ட் ஹியர்.
Javier Yu from
Southern Railway Headquarters Hospital, Chennai.
Your topic, the case presentation is pipeline DSA.
Yeah.
Yes. Now you start your presentation.
Yeah. In traditional days, we are done angiography with the fluoroscopy. In that image, we acquired images, underlying and overlaying images. So we can't determine the results clearly. After that, digital subtraction angiography was found. What is digital subtraction angiography? It is a digital method subtraction. First, scout image was taken. After that, contrast injected image was taken. It's digitally subtracted, and after that, its subtracted image appeared. It was only the vessel. Everything was disabled. Can only see the vessel anatomy and physiology. I am going to explain about the biplane DSA. In biplane DSA, it has 2 arms. One was C arm and another one was L arm. C arm can rotate 240 degrees and L arm can rotate 180 degrees. Everyone knows single plane DSA has only one C arm, but in biplane DSA it has one C arm and one L arm. Okay, I am going to explain the recommendation based on Siemens Arctic Z biplane DSA. It's tube. Everyone knows that it's working based on thermionic emission. It means when filament heats, it emits the electrons. Its filament made up of tungsten. It has 3 filaments, one micro, small and large, and also triple focal spot, and also micro and small and large. Operating tube voltage 40 kVp to 125 kVp. Operating current 10 to 800 mAh. It's a pulse time. This one pulse time means there is a time between 2 pulse. Pulse frequency means number of pulse per second. It's called pulse frequency. It has filters 0.1 mm, 0.2, 0.3, 0.6 and 0.9 mm thickness.
These are all the detector specification. It has a two large detectors which have sufficient to cover the abdominal large FOB. It has these are the magnification fields of 48 cm, 42, 32. These are all the magnification factor. If it reduce, it will increase the magnification. It's a flat panel detector used is a material cesium iodide because it's more sensitive and fast and cheaper. More sensitive allows to lower dose radiation. That's why we are using a more sensitive one. It brings a more safety because it's care profile. Care profile means combined application for radiation exposure control. We are using a fluoroscopy continuously for the patient position, but in this we have acquired one image. After that we can position. If move the table, there is a guideline appears and it's guide us to make a position and grids and make everything, collimators. Its rectangular collimation differs from normal collimator because normal collimator only can move upwards, downwards or right or left, but it can move any angulation, right corner to left corner to bottom corner. It's a wedge filter. During thoracic procedures, lungs need a less radiation, spine need a higher radiation. During that time we can use wedge filter for both lungs. It reduces the radiation at lung field. Finger filter during variable both legs PSA. In middle of the area no need radiation. That time we can use a finger filter. There is a lead shield. These are lead shield. This one is a wall mounted lead shield. It can move anywhere in the room. Collision protection. This machine having a lot of sensor for collision and crushing points. It will automatically slow down on that particles. These are having 8 monitors. And this one the machine control panel, and this one on the within the procedure room. It can use like a keyboard. This one use like a normal mouse. These have a lot of question modes. This one on the coolant circulation for tube heating reduction. This one road map which can be appear background of the live image. It can be navigate the guide wire or catheter something. It one is a 3D DSA rotational angiography. We can acquire from the DSA. It's principle like a CT. It can appear in 3 planes. It's like a CT only. This artifact, this is a motion artifact, can be corrected with a pixel shifter. It is a pixel shift can be correction with applications. It's a artifact. It be corrected with the pixel shifter. Calibration is more important for the post-processing techniques. Calibration, if done perfectly, means our post-processing details will be more accurate. First one is was aneurysm measurement. This was the quantitative vascular analysis, which is give the more details about vascular, which will determine the very helpful to health of the vascular of patient. This one was the aneurysm analysis. For aneurysm analysis, we can point the 3 points in that one image. One was proximal point, one of mid of the aneurysm, and one the distal point. After that, we can get a detail of length and diameter, room size of aneurysm. This was the fusion image of post-processing. This one during pre-coiling, this one post-coiling image. This one was the fusion image of the. So the aneurysm was different in color. It is also given stent stimulation because during quantitative vascular analysis we can use a stent stimulation. It will give more detail about the which size of the stent can be used. Like that details will give by the software itself. In this machine we can use the artificial intelligence also. In artificial intelligence we can control the machine via voice. Conclusion, our afternoon first session, Dr. Operating strategy shows lot of stenosis aneurysm images. For like that patients, it gives a more accuracy treatment with the biplane DSA is possible. And exact size of treatment material choose based on the TTL which given by advanced post-processing techniques. It will increase the workflow and efficiency and reduce the procedure time and injecting contrast volume. Thank you. Hospital, where I work with pipeline DSA.
Okay. Now we have explained regarding the pipeline DSA. First question. What is town's view? What is town's view? Town's view.
Town's view is taken for a skull.
What it is? Town's view means some projection, some angulation by which you can do the angiography. Yes or no? What is town's view?
It's we can give an angulation like LP view of 20 degree of 10 to 30 degrees.
Where? Which angulation?
Cranial.
Cranial. Okay. What is image intensifier?
It's image intensifier used in older days, which is used inside of the fluoroscopy, sir.
Okay.
And it has a photocathode and it will increase the electrons, photons, amount of photons.
Why it is used in fluoroscopy?
Because we can give take an image with low radiation and it will increase the number of photons. We can take an image with low radiation, sir.
Low radiation. How much it is increased? In which grade? What is the input phosphor of the image intensifier? What you have said? Cesium iodide.
Yes, sir.
Our other phosphor. What is the benefit of putting cesium iodide in input phosphor rather than other phosphor?
The cesium iodide is more sensitive, sir. More sensitive means it will react with low radiation. I taken during the time.
You have taken. It is your own original picture.
But the neurological images are not taken. In our department, we do abdominal procedures only we are doing, sir. The neurological pictures taken by application specialists, sir.
Subrata Pal.
Or organic foreign bodies like eatable or peanuts, etc. Children who have objects in their mouth while they are playing, running or laughing at risk. Definition: foreign body expression is a condition occurs when any solids or liquid substances inhaled into the respirator. Three types of foreign bodies: laryngeal foreign bodies. These manifest with trophy or horse cough, apnea, hemoptysis, dysphagia, wheezing and cyanosis. Fatal aspiration may occur due to the foreign body or its inflammatory reaction. Tracheal foreign bodies, these manifest as cough, hoarseness, dyspnea and cyanosis. Bronchial foreign body, coughs, wheezing, blood streak, sputum may occur. History of choking, gagging, paradoxial coughing, history of eating substance like groundnut etc. is vital in the diagnosis. What are the usual foreign bodies? Organic food, peanuts, popcorn, seeds, hot dogs, vegetable matter, non-food bones, or inorganic toy parts, carry-ons, paint rope, tracks, pins, nails, screw, bullets and sizzling. Investigation: normally plain chest X-ray, 80% of laryngeal foreign body and 15 to 28% of bronchial foreign body can have normal. Normally findings plain chest X. Normally findings plain chest X दोनों में ट्रैकिया में अटका हुआ है दिख रहा है इसमें. और नीचे एक जो पिक्चर है उसमें
Points in the trachea or esophagus?
Esophagus.
Why do you say so?
Now start. Good. Best of luck.
थैंक यू सर. सो मेरा एक टॉपिक है पोस्ट ट्यूबरकुलोसिस सीक्वेंस टेस्ट. मेरा नाम नीरज है, नीरज कुमार पांडे. तो पोस्ट ट्यूबरकुलोसिस क्या है? These are the radiological changes in the chest which are secondary to complication of primary or secondary pulmonary tuberculosis. These changes may vary from mild to severe. Complication of tuberculosis after treatment complication can often be misinterpreted for another disease, so it is securely. Some residual changes can be compatible with life and not cause any symptom. Is weight loss, chronic productivity curve, fatigue, dyspnea and hemoptysis and fever. It is alveoli वगैरह जो रहते हैं
Bronchus alveoli, it is a separate thing. Term is bronchiectasis. What is traction bronchiectasis? You have already written.
Trachea में sir calcification, small calcification.
Now your time starts now. Good evening to all. My topic is the extramarrow soft tissue blood element creation mimicking the marrow outside bone. And extramedullary of the hemoptysis in the adult fails. Various extramedullary sites take on the role of blood formation. The favored sites are the liver, the spleen and the paraspinal region of the thorax. Extramedullary hematopoiesis, that is the EMH, is defined as hematopoiesis occurring in organ outside of the bone marrow. It is a compensatory mechanism of the body for production of the primitive blood cell lines.
कैसे मालूम पड़ा आपको?
वो जो सर एक किया हुआ है साइटोलॉजिकल जो एक किया वहाँ पे
That is after only after syndicated
deficiency.
So so your X-ray interpretation should be parasternal mass.
Paraspinal
or something else.
Not a star.
Like cannonballs. It has also the French term that translate to balloon release, also are known used to describe in the same appearance. And the appearance like this, the cannonballs in CT scan, CT axial scan, and in X-ray, this is the appearance. Cannonball lesions in lung fields are most commonly due to hematogenous spread of the primary malignancy elsewhere.
Can it be artifact? Can it be artifact?
Maybe some artifact in cassette or.
How can you resolve it? मैं बोलूँगा ये पेशेंट का आर्टिफैक्ट उसका बॉडी में कुछ था, वो एक्सरे करने के बाद ऐसे आ गया, उसको रूल आउट कैसे करोगे?
Then you check the patient.
नहीं there is रिपीट करने से पहले और कुछ करने का तरीका है जो उसको नहीं वो आर्टिफैक्ट नहीं है ये एक्सरे में है
इसका साइड में सर इसके अंदर में ये नहीं है ब्रोंकस जो होता है सर ब्रोंकस का साइड.
We are in the radiology field and we faces many times eclampsia condition in the patient. Now, so first question, what is the eclampsia? Eclampsia is a rare disorder of the esophagus. As you know, esophagus is also known as a food pipe. Eclampsia results from a malfunction of the nerves that control the movement of the food through the esophagus. It makes it difficult to swallow food and liquid.
Finding of hiatus hernia.
This patient sir.
No, hiatus hernia तो एक्लेसिया हो गया. hiatus hernia के एक्सरे में क्या दिखेगा या वेरियस वाले में क्या दिखेगा?
hiatus hernia केस में क्या होगा सर, जो हमारा esophagus जो होगा वो आपका जो डायफ्राम से थोड़ा ऊपर में दिखेगा और स्टोमक वाला जो रीजन है
it is the one of the best platform for the radiographers. They should learn anything. अगर तुमको कुछ प्रेजेंट करना है तो तुमको कुछ सीखना है, अदरवाइज कोई आके स्टेज में प्रेजेंट नहीं कर पाएंगे. एंड इट इज अ ग्रेट क्रेडिट टू ऑल दी 6 radiographers who have presented here in a national conference. It is one of the most important. So everyone should learn, and I am requesting to all, whenever you are doing your job in your particular area, आपका जगह में जो अपना काम कर रहे हैं वो तो अच्छी बात है, बट सम एकेडमिक इश्यूज शुड बी डन. सम एकेडमिक आप पढ़ाई करो, कुछ सीखो. अगर कोई कॉन्फ्रेंस आ रहा है कुछ सीखा कर ले, उसको कैसे इम्प्लीमेंटेशन होगा इतना काम में वो थोड़ा सा ध्यान दो. एंड याद करो जो नेक्स्ट कॉन्फ्रेंस जब हम जाएंगे आई शुड प्रेजेंट एनीथिंग, ये होना चाहिए, ये सबका जील होना चाहिए. एंड दिस इज द एकेडमिक फोरम. ये नहीं है कि हम आएंगे, घूमेंगे, मस्ती करेंगे, गाना गाएंगे, चले जाएंगे. That is not the aim of national conference. National conference means you should share your knowledge among all the radiographers. हम लोग कुछ सीखे हैं, हम लोग काम कर रहे हैं, हम जितना जानते हैं आपको समझा के देने की कोशिश करेंगे. आप भी कुछ सीखे हैं, आप भी आके प्रेजेंट करो. We should learn from you also. It is a symbiosis, combined sharing of knowledge among all of us. We are above all, we are all the staffs of radiology department, and radiology nowadays is going high and high. Everybody has appreciated that. Before 10 years radiology and after 10 years radiology, it is beyond imagination. So nowadays, every conference, every academic session should be there in yearly twice or thrice, and everyone should attend the academic session, learn something, and it should be utilized in your day-to-day work. So excellent performance by 6 radiographers who have presented the e-poster presentation. First topic, the scientific session started at 9:30, sir. Before that, 9 to 9:30 there is a breakfast session. Everyone should come at least at 8 o'clock, 8:30. Then 9 to 9:30 breakfast. 9:30, sir, we will start our session. First session is interpretation of chest radiograph. Extremely important for radiographer. Extremely important, and the topic will be presented by Dr. Gajendra Kumar Das, ACMS from Bikaner. वो बहुत दूर से आए हुए हैं, आपको बहुत सारे संदेशा देंगे.
Tomorrow at 4 o'clock or 5 o'clock, between them we will start here with a bus to Babughat at launch. There is a launch from West Bengal government. That is Sumangal. We will be here. We will return here again, and dinner is for you here. And there will be a snacks, tea, coffee, and drinks for you. Thank you.
It was really a tough competition, but somewhere we have to come into some conclusion. So today's e-presentation, the third prize goes to third. This is the third prize goes to Mr. S. Kaviyalu from Southern Railway. Congratulations, Mr. S. Kaviyalu. This is for the, I think, certificate of participation. Prize will be given tomorrow. Prize will be given tomorrow. This is the participation certificate. Come this way.
Sir.
Shah Khan. Mr. Pradeep Paramani. It's a beautiful case. Actually, we have a lot of discussion before regarding the case. So thank you, and you have presented very well, and you have also maintained the format what your Dr. Saul has given. Thank you.
Sir, सामने देखिएगा इसमें.
Come on the stage for a participation certificate. Mr. Krishnendu Das, please come fast.
Thank you, sir. स्माइल रखिएगा, वीडियो हो रहा है सर.